Thank you very much for your kind words, Professor Stojanovic, and good morning, everybody. I hope you slept well after this wonderful dinner yesterday. And as you see, we'll start with the topic acute abdomen. But first of all, I would once again like to thank Professor Stojanovic that she's hosting this course. It's a wonderful day today, and I'm convinced that at the end of this day, we'll be all very satisfied what has been presented. Now, the learning objectives, lecture objectives are written here. I would like that you become familiar with the most frequent causes of the acute abdomen, that you know how to select the appropriate imaging techniques in the diagnostic workup of an acute abdominal pain, and to appreciate the growing role of contrast-enhanced CT for the evaluation of an acute abdomen. But let me begin with a practical case. A case where we initially at our department missed the diagnosis. We are dealing with a 69-year-old female, had a fall on the right flank 2 weeks ago. Now she has right lower quadrant pain and flank pain, elevated CRP, and the CT diagnosis in another hospital was retroperitoneal phlegmon. Then she was transferred to our hospital, and we repeated the CT examination, and we made this differential diagnosis. You can read it from 1 to 4. Has someone an idea? Perhaps let me show a little bit more in detail the various slices. From the diaphragm down to the pelvis. Well, the diagnosis is a retroperitoneal abscess secondary to perforated appendicitis. And on these CTs, you can easily recognize on these MPRs that we have here the appendix located dorsally of the cecum. With a yellow arrow is marked a fecalith, and here is a walled-off perforation secondary to this walled-off perforation, and with this secondary retroperitoneal abscess. What is the message of this case? The message is twofold. First, multi-detector CT, because of the possibilities of coronal and sagittal views, facilitates the diagnosis. And the second message is that acute appendicitis is the most common cause of an acute abdomen, as shown in this study, a multi-center study from the Netherlands, among more than 1,000 patients. The second cause of an acute abdomen is diverticulitis, bowel obstruction, and so on. Now, a common clinical view how to choose an imaging method for a pain. People are looking at the pain location. And the most common cause of pain in an abdominal quadrant in the right lower is acute appendicitis, in the left lower is acute sigmoid diverticulitis, in the right upper quadrant, acute cholecystitis, and in the left upper quadrant we have relatively infrequent causes of an acute abdomen. Diffuse pain, the most common causes are listed here, and the causes of epigastric pain and flank pain are listed here. Now I have underlined all the pathologies which I will discuss in the next 25 minutes or so. An important cause of diffuse pain is bowel obstruction. You have heard about bowel obstruction yesterday in the excellent lecture of Dr. Senica, so I will not address this topic in my lecture. How is the modern approach to imaging in acute abdomen? I would summarize that contrast-enhanced CT is a technique of choice because of ready access and widespread obesity. Information obtained outweighs definitely the risk associated with radiation. Unlike this, ultrasound is notoriously operator-dependent technique, but it's still the initial investigation technique in patients under 18 years of age, as long as they are not obese. Conventional X-ray has a certain role, as we have heard yesterday, in bowel obstruction, but the role is very limited. and it's also useful, for instance, for localization of catheter placement. And MR in acute abdomen is used when there is a contraindication to CT, and of course in pregnant women. So let's begin with acute appendicitis. And if you want to discuss, if you want to diagnose acute appendicitis, we should of course be a little bit familiar with anatomy and pathophysiology. The location of the appendix is variable, and this explains the multiplicity of clinical appendicitis presentations. We consider a diameter of above 10 millimeters abnormal. The cause of acute appendicitis is a luminal obstruction, which can be caused by fecalite, lymphoid hyperplasia, and so on. And then, because of obstruction, a fluid accumulation will occur with luminal distension, bacterial overgrowth, and inflammation. And compared to uncomplicated appendicitis, complicated appendicitis with perforation will increase the mortality by 2 to 10. Now, there are numerous data regarding the accuracy of imaging at detecting appendicitis. In the USA, there is a strong consensus that CT should be used instead of ultrasound, while in Europe, ultrasound is more frequently used. Ultrasound, because it's associated with ionizing radiation, is of course the modality of choice in children and during pregnancy. But the meta-analysis has shown that the sensitivity and specificity of CT is always better than compared to ultrasound. And a study at UCLA has shown that when compared the years 96 to 2006, during this decade, there was an increase of preoperative CT, preoperative before appendectomy, from 20 to 85%. And in the same time period, the overall rate of false positive diagnosis and of overall rate of appendiceal perforation decreased down to these figures, 3 and 5%. So these results suggest that a preoperative use of CT will improve the outcome in patients of having acute appendicitis. The diagnostic criteria for ultrasound in acute appendicitis are a non-compressible appendix, diameter more than 10 millimeters, and the appendix has a target appearance with a hypoechoic muscularis propria, a hyperechoic submucosa, and a hypoechoic mucosa. And of course, with Doppler, you can see then the perfusion of the appendix wall. Now, an example of a patient with acute appendicitis. The diagnosis was done on day 1. A retrocecal located appendix, diameter more than 10 millimeters, and you can also recognize an appendix. But somehow the patient was not operated at that day, and the pain increased during the night. And the other day, we could recognize only periappendiceal fluid, and the appendicolite was no longer visible, so this was an indication, this periappendiceal fluid, of perforation. But with CT, and this is a big advantage of CT, you can much easier recognize or demonstrate the various stages of disease in acute appendicitis. And this patient with uncomplicated, that is non-perforated appendicitis, he shows an appendix in retrocecal location. The diameter is more than 10 millimeters. You can recognize a fecalite at the base of the appendix. This is again the increased diameter. There's an inhomogeneous wall enhancement, and there's periappendiceal stranding. And this is acute appendicitis without perforation. This is a patient with free perforation, so a complicated appendicitis. And what are the criteria? Again, we can recognize the appendix. We can recognize, this is the course of the appendix, that the diameter is more than 10 millimeters. We can recognize a fecalite at the base, but there are defects in the enhancing wall. That means we have, after IV contrast administration. We have ischemia partly in the wall. We have even interluminal hyperdensities corresponding to interluminal hemorrhage because there is ischemia of the wall, because the wall is distended. And the most important is that we can recognize interperitoneal fluid indicating peritonitis, and this occurs, of course, only after perforation. This is a patient with complicated acute appendicitis with perforation. She was a lady 2 weeks ago treated for gastroenteritis because of pain. She had pain in the right lower quadrant. Ultrasound was performed, but this image was not completely understood, and therefore CT was done, and CT shows a mass lesion with rim enhancement, with a fecalith. This mass lesion contains extraluminal gas. The mass lesion displaces the cecum anteriorly and corresponds, this mass lesion, to a retrocecal abscess following perforation and walled off this perforation by adjacent omentum or the cecum and so on. So not a free perforation, but a walled off perforation. Now in the right lower quadrant, patient with pain, this is of course not always appendicitis, and there is a long list of differential diagnoses. We can have intestinal mimicus or urogenital mimicus. We can have mimicus which are more common and those who are less common. And I will only pick up 2 of these pathologies from this list. And the first one is acute cecal diverticulitis, which presents, as in this case, of course, on the right side. The pathophysiology that we are dealing with a congenital or a acquired right-sided colonic diverticulum. It occurs more commonly in the Asian population. And the inflamed diverticulum may enhance or contain gas, or a fecalith, or enteric contrast, as in this case. And of course, the differential diagnosis in this patient, in particular when they are over 50 years old, is a perforated colonic carcinoma, in particular if there is evidence of a large soft tissue mass. But in this case, the diagnosis is evident from this small diverticulum and adjacent inflammatory reaction. And the other important differential diagnosis is pelvic inflammatory disease. Of course, occurs only in female patients. Pelvic inflammatory disease encompasses a spectrum of inflammation, of infection in the female reproductive system. And of course, such a tubo-ovarian abscess should not be confused with a dilated appendix. The area in this patient, cecum and appendix, is completely normal. So this is a typical finding of a tubo-ovarian abscess in this lady with right lower quadrant pain. Let's move now to the left lower quadrant pain. And again, the list of differential diagnosis, and the most common cause of left lower quadrant pain is acute diverticulitis in the sigmoid or the descending colon. The other differential diagnoses are listed here, and again, urethral stone, of course, is also an important differential diagnosis. Just a few general remarks to acute diverticulitis. We know that colonic diverticulosis occurs in 65% of the population above 65 years. But only 25% of these 65% will have diverticulitis once in their lifetimes. And the CT findings are wall thickening, more than 4 millimeters, and here the sensitivity is very high, and a fat stranding, and the incidence of complications in decreasing frequencies is pericolonic abscess, peritonitis, fistula, and colonic obstruction. So colonic obstruction is not very frequent in not a very frequent complication acute diverticulitis. The most common complication is an abscess, and if we can recognize this patient, the sigmoid with pericolonic gas or oral contrast material, then of course we can diagnose this mass lesion. You can say we are dealing here with an abscess It's a walled-off perforation because there is no free fluid. When talking about diverticulitis, you should be aware that the disease stage in acute diverticulitis is often determined by the so-called Hinchey classification. The Hinchey classification is an aid for the surgeon to decide whether the patient can be treated conservatively, conventional, or if the patient requires a surgery. And here are the 4 stages. And patients who show a mass lesion, an abscess, then ideally, if the abscess is more than 4 centimeters, one can perform a percutaneous drainage, while if there is free fluid indicating peritonitis, then these patients require immediate surgery and usual stoma formation. And an example, this is a patient with diverticulitis stage 4, clinically sepsis and epigastric pain as initial manifestation of a intravenously perforated diverticulum. This explains the subacute thrombosis of the distal mesenteric veins and then the gas within the inferior mesenteric vein within the portal vein because of this perforation here in the diverticulum in the sigmoid, and the patient had also free fluid around the liver indicating generalized peritonitis. Quite an important differential diagnosis is epiploic appendicitis if a patient presents with left lower quadrant pain, and by definition we are dealing with a torsion of venous thrombosis of appendices epiploicae with ischemic or hemorrhagic infarction and second inflammation. The appendices epiploicae are usually not visible because they blend with the surrounding fat. However, if there is ascites, they become visible because of the different attenuation of these appendices and the fluid, the ascites. And on CT, we recognize a core fat mass measuring 2 to 4 centimeters with surrounding inflamed tissue, typically located in the sigmoid and descending colon, because that's the location where we have most of these appendices epiploicae. And they typically, and this is also important, abutting the anterior wall, because this is the location of the appendices. They are not laterally or posteriorly, they are anteriorly. And once we have made the diagnosis, we should be aware that there is a spontaneous resolution within several days or few weeks. There is no abscess formation, so there is no indication for surgery. From right lower and left lower quadrant pain, I'm moving to right upper quadrant pain. And the most common cause, by far the most common cause, is acute calculous cholecystitis. Acalculous cholecystitis is much less common and typically occurs in patients with total parenteral nutrition on the ICU. And 1/3 of the cases belongs to the differential diagnosis as listed here. And according to the ACR appropriate criteria, in patients with suspected acute calculous cholecystitis, ultrasound represents the basic examination, while CT is used for the detection of complications. Now, the diagnostic ultrasound criteria in acute cholecystitis are well known. We'll look for a gallbladder distension. The diameter will be typically more than 4 centimeters. There's a gallbladder wall thickening. There's striated wall thickening with this lucent and echogenic bands, Murphy sign, pericholecystic fluid, and the gallbladder stone typically impacted in the cystic duct. Now, CT in acute cholecystitis is used for detection of complications, and one sort of complications is acute gangrenous cholecystitis, and the criteria are gas in the wall or lumen, interluminal membranes because of the hemorrhagic mucosa, for instance, an irregular or absent wall, and the pericholecystic abscess following perforation. Another well-known but rare complication is acute emphysematous cholecystitis. Typically occurs in older men with diabetes, and we can recognize even this pathology on a plain film because on this upright patient there's a gas fluid level in the gallbladder lumen from gas-producing anaerobic bacteria, and the patient here is supine in CT can recognize again the gas in the gallbladder lumen, and if there's disease progression, as in this case, the gas from the gallbladder lumen dissects into the gallbladder wall. From localized pain, I'm moving now to diffuse pain. And the most common causes of diffuse pain are gastroenterocolitis and bowel obstruction. But once again, this topic has been covered yesterday by this excellent lecture of Dr. Senica. I will only focus now on acute bowel ischemia and GI tract perforation. Now, bowel ischemia is not a frequent cause, but it is, I have it to mention because it's very important, because it has many consequences for the patient. Now, the causes of acute bowel ischemia are mainly occlusion of arteries, less common occlusion of veins, and quite important is this cause non-occlusive disease because of hyperperfusion. I will talk a little bit later on this one. And the classification, we should be aware that acute bowel ischemia occurs much more commonly in the large bowel and less commonly in the small bowel. And most at risk are elderly patients with cardiac conditions or post-operative after surgery for the coronary arteries, because this induces a hyperperfusion and will cause a non-occlusive acute bowel ischemia. Or less common, younger patients known to have vasculitis or coagulation disorders. Let me just show, and before showing an example, I would make a point on the stages of the various in acute bowel ischemia. We have to be aware that we have first at the beginning a transient bowel ischemia, which can be followed by necrosis and of submucosal and muscular layers, and in the end stage a transmural bowel necrosis may occur. But in the majority of cases, if the diagnosis is recognized, there is a restitution of the bowel wall because we have some kind of hypoperfusion, and the first signs of hypoperfusion are mucosal erosions, hemorrhage, necrosis, but the integrity of the deeper mural layers are preserved, so only the mucosa is involved. However, if the diagnosis is, the pathology is not recognized, then the pathology can continue. There will be a breakdown of the mucosal barrier with the bacterial invasion of the wall, and this contributes to the further development of necrosis. And finally, if there's a transmural bowel necrosis, there will be a bowel infarction, require immediate surgery. And in order to be able to diagnose, we should know the criteria on imaging in acute bowel ischemia. And this is, CT is important because on the biphasic CT, in the arterial and venous phase, we can recognize various signs. First of all, if there's a direct demonstration of the occlusion of the artery or the vein, of course, then the diagnosis is easy. But we have the typical, and that's what we typically can see, is a target sign. However, this is a non-specific sign, but nevertheless, we should be aware that we can recognize a hyperdense mucosa, which is hyperdense because of hemorrhage, blood clots in the mucosa, or because of recovery, again, contrast agent perfusing the area of the mucosa. The second layer is a hyperdense submucosa, and the third layer is a hyperdense muscularis propria, which can be hyperintense because of contrast agent, or if there is no contrast agent have been given, but it's hyperdense, then of course of hemorrhage. But what is important if you want to diagnose these various stages, we should not give all contrast because this will obscure wall enhancement. A non-enhancement, of course, allows a definitive diagnosis because we know that we have a compromised arterial flow. Pneumatosis and portal venous gas are well-known signs in transmural necrosis. Luminal dilatation is secondary to missing peristalsis, and of course mesenteric stenocytes are non-specific signs but also occur in advanced stage of bowel ischemia. And an example, this is an elderly patient with coronary artery disease. He has diffuse abdominal pain because the peritoneum is somehow involved, which causes pain, and he has a thickening of the wall of the cecum, of the ascending colon. We have a hyperdense mucosa because of hemorrhage and or perfusion. We have the hypodense submucosa, and we have somehow a hyperdense outer layer indicating blood or contrast agent, but there is no gas, it's just a thickening, and this is the same pathology shown in the coronal and sagittal view, and we can recognize there's obviously some bleeding, but there is no transmural necrosis in this patient, and he recovered after a few days. This is different from this patient, classical non-occlusive mesenteric ischemia in a patient with a cardiogenic shock. He has necrosis and this pneumatosis in the wall of the bowel and in this portal venous gas. So this is indicative of a transmural necrosis, and this patient requires obviously surgery. Now, another important, pathology has been addressed yesterday, is localized small bowel ischemia in bowel obstruction. And this typically occurs in a strangulating small bowel volvulus, and in this patient it was due to an adhesive band following operation several years ago, and this intraoperative ischemia and infarction of the ileum were found, and CT preoperatively shows as a strangulated bowel obstruction. So if the bowel is obstructed by strangulation, we have first of all a predominantly venous disorder because the blood in the veins cannot flow back to the portal system, and because of the strangulation, no blood is coming in from the arterial side, so we are dealing primarily with a venous congestion. This causes hemorrhage in the wall. However, we have also parts of small bowel wall which show non-enhancement because of the arterial inflow, because of strangulation, and this causes images with areas of wall, hyperdense wall because of hemorrhage, and thin walls because of no arterial flow, and then we have ascites and stranding of the mesentery, all additional signs of mesenteric ischemia. If mesenteric ischemia continue, of course, then we can see as a complication a perforation. And this is the last topic I would address, the GI tract perforation. But there are various causes of perforation, and this is a list where you can see most commonly a perforation depending on the location, the stomach, small bowel or large bowel. And I've already discussed the perforation in case of appendicitis, diverticulitis, which is usually walled off. Free perforation is rare because they are covered, walled off by adjacent anatomic structures like omentum. And of course, perforation may also occur in these pathologies, and in ischemic colitis, perforation may occur, and of course, following intervention. And once again, a free perforation is diagnosed by the presence of free extraluminal gas, while a walled-off perforation is demonstrated by the presence of an abscess. And typically, several years ago, we have been using a conventional X-ray for the diagnosis of a free perforation for the demonstration of free extraluminal gas, but the sensitivity is 50%, so you can, it's like you can flip the coin. However, the sensitivity for the demonstration of gas with CT is much higher, and we can differentiate between direct CT findings and indirect CT findings. Direct CT finds presence of extraluminal gas and a ruptured wall, of course, and indirect findings are these as mentioned here. And let me just show you two cases. A patient with interperitoneal perforation because of a pre-pyloric ulcer. He had in his history non-steroid anti-inflammatory drugs medication, and CT, and also this of course is visible on the plain film, but much more clearly on CT, that you have free interperitoneal gas, quite a lot of gas, but in the soft tissue window we can recognize this thickening of the anterior wall of the stomach, indicating the location of the perforation. So CT can not only show the free gas or the extraluminal gas, but can also demonstrate the site of the perforation, which is of course very helpful and is more or less impossible on plain film. And the last case, this is a patient with minimum of free interperitoneal gas. The patient had diffuse abdominal pain. Plain film was negative, but CT clearly showed that we have a small amount of gas below the diaphragm in the interperitoneal cavity, a small amount of free gas along the falciform ligament, and in the soft tissue setting, the CT also showed the cause of the perforation, namely a foreign body, a toothpick, which has been ingested by the patient. So I come into my summary. I would say that in patients with acute abdomen, CT clearly has a higher accuracy than ultrasound. CT has a substantial impact on diagnostic certainty and outcome. In patients with right lower quadrant pain, think first of appendicitis or exclude appendicitis and then consider alternative diagnoses listed. And people use first ultrasound if they're young patients, or then go immediately to CT, in particular the elderly patients. In left lower quadrant pain, most common cause is diverticulitis, especially the older the patient are. And in patients with diffuse pain, you are still using, let's say, conventional X-ray, at least in order to exclude foreign body, which can be positive on X-ray. And but usually we're going directly to CT, and do not forget that bowel obstruction is the most frequent cause of diffuse pain. And I would like to say that there's some kind of change of paradigm in diagnosing acute abdomen. Today we are no longer doing laparotomies, but we are going immediately to CT. And for those who are interested to hear more about acute abdomen, we'll have the ESCA meeting in a month from now in Dresden. They have the pleasure that our local, that the president of this meeting, the local organizer, Professor Michael Agnardo, is present here. And I would like, of course, that he will have, and I'm convinced that he will have a huge success with this Congress here in the beautiful city of Dresden. Thank you very much.